district pulmonologist in Ahmedabad, and assistant professor in pulmonology in Women Medical and Dental College. Very important topic is that effective oxygen therapy, best practice from critical care of the home management. So before starting today's sessions, we have a lot of collaboratives from the PMA and from Pakistan Physiological Society, Pakistan as Association of Pathologists, and Women Medical College, Ahmedabad, and ex-Azad Jammu Kashmir Medical College, Muzaffarabad. And over to you, Professor Rashid Mahmood. To start today's session, we'll request you to recite the Holy Quran.
Right. Right, sir. जज़ाकल्लाह। सर, ये सूरत आल इमरान की आयत है। अऊज़ु बिल्लाहि मिनश
की आवाज मुझे नहीं आ रही,
शैतानिर
लगी देखो साउंड में।
जी, आवाज नहीं आ रही?
आ रही है मैडम, आ रही।
चल। अऊज़ु बिल्लाहि मिनश शैतानिर रजीम। बिस्मिल्लाहिर रहमानिर रहीम। ज़ुय्यिना लिन्नासि हुब्बुश-शहवाति मिनन-निसाइ वल-बनीना वल-क़नातीरिल-मुक़न्तरति मिनज़-ज़हबि वल-फ़िद्दति वल-ख़ैलिल-मुसव्वमति वल-अन'आमि वल-हर्स ज़ालिक मताउद-दुनिया वल्लाहु इंदहु हुस्नुल मआब। तर्जुमा: लोगों के दिलों में बीवी बच्चों की मोहब्बत, सोने और चांदी के और घोड़े निशानदार और मवेशी और खेती, ये तो इस दुनिया की जिंदगी का सरमाया है, और आखिरत की बेहतर जिंदगी तो अल्लाह ही के पास है। सदक़ल्लाहुल अज़ीम।
जज़ाकल्लाह, बहुत खूबसूरत रेस्टोरेशन ऑफ होली कुरान एंड ट्रांसलेशन इन उर्दू। थैंक यू वेरी मच। वेरी इंपॉर्टेंट आपने जो चीज़ें बताई हैं। डॉक्टर मुनीर साहब, वी स्टार्टेड दिस वेबिनार इन ड्यूरिंग द कोविड and almost without any delay or missing any of the Sunday, we are continuing this webinar. And we are highly obliged, Professor Salma Kondi, and other PMA members who are cooperating with us. And with the cooperation of these stalwarts, we are able to continue these webinars. No doubt the participants are few, but after this, we will upload these videos on Women Medical and Dental College website, and also our Pakistan Association of Pathologists website, Professor Mulazam Hussain Bukhari. And almost hundreds of the people like and they will listen it. So before starting today's session, Dr. Munir Abbasi, you will introduce yourself a few minutes and then we'll continue it. Over to you, Dr. Munir Abbasi Saab.
Thank you, Dr. Bukhari Saab. I'm Munir Abbasi and I'm working as a district pulmonologist in Benazir Bhutto Shahid Teaching Hospital, Ahmedabad. I've been working there for the last 5 years. Before that, I was in Rawalpindi at Fuji Foundation Hospital as a pulmonologist. I've done my MBBS from IU Medical College and I've completed my FCPS pulmonology training in Ahmedabad as well. I've been working as assistant professor of pulmonology since 2022 in Women Medical and Dental College. I was informed of this initiative by Pakistan Medical Association and Women Medical and Dental College by our Professor of Medicine, Dr. Mir Jalal, and I'm highly obliged and thankful to him for showing me this way to help me improve my teaching and clinical skills. This was the first topic that I thought of, and I decided to choose this topic because oxygen therapy is one of the most misused commodity in inpatient as well as in outpatient departments. Second to painkiller abuse, and like we have seen in Ahmedabad, or in Pakistan, and usually in winters, nebulization practices. So I thought, why not start with oxygen therapy? I have designed this presentation to be an interactive one. If participants want to, they can join this interactive session. All they have to do is either scan the QR code on the screen, or they visit our website at http://pvox.app, enter the session ID, and that's it. And you will be part of this show. And I would like the participants to answer a few questions that are related to this presentation. So in this way, I hope to make my message conveyed effectively compared to anyone else. So it's very simple. You can either use your phone to scan this QR code, and you will be directed to the link. Or if you are using your laptop, go to vivox.app in Chrome, Firefox, Brave, whatever browser you are using, enter the session ID 148418448, and then you'll be part of this session. So as a starter, this is the first question. What challenges have you people faced with oxygen therapy in clinical practice? Either those were compliance issues, patient affordability, lack of oxygen therapy training, lack of oxygen supply, workload, etc. These are general questions. So the timer ran out. There was no answer. But then recently published research papers like in 2022 and 2023 suggested that there were certain important factors that were associated with uh, improper or ineffective oxygen therapy. Some issues that the health caregivers face were lack of training, high workload, limited oxygen supplies, absence of local guidelines as well. Then appropriate knowledge was not there. Performance in oxygen therapy, there was no standardization available for that. There was no knowledge and correct practice for oxygen therapy. There was insufficient monitoring. Even effective hospital equipment were also mentioned as a factor in the as a barrier in giving effective oxygen therapy. So in the second study, which was this which was published in this critical care research practice 2023, nurses were identified as having only 12.5% of the study sample knew what was good in giving oxygen to the patients, and only 25% showed favorable performance. So 75% of the ICU nurses didn't have any effective knowledge of how to give oxygen to patients. So overall, oxygen implementation protocol and understanding was observed in only 11.25% in this study. So this shows how bleak this situation is. So there's another paper on acute oxygen therapy. It's a review of all the oxygen prescribing and delivery practices in the UK. It was published in I think 2015. So they identified certain factors as well. For example, familiarity with oxygen delivery devices was lacking. There was insufficient medical training education for doctors as well as nurses. There was a lack of understanding of the therapeutic effects, the role of oxygen, and the risks of oxygen therapy. Time constraints were also noted as important factor affecting the poor performance of staff in administering oxygen therapy. Then other issues like difficulty in changing long established behaviors, lack of enthusiasm by senior clinical staff, difficulties between doctors and nurses, communication difficulties, lack of full-time staff or staff turnover, and there was so they decided they thought that people over the past many years have been thinking on this thing, and they decided that we want to improve this situation. So a number of interventions were introduced. For example, introduction of oxygen alert stickers, dedicated oxygen charts, informational posters, information for educational sessions for these specialties and nurses and doctors, etc. But overall, as this study further observed, the effects of these interventions was very poor and not significant when expected to be. So the learning objectives in view of these uh, knowledge snippets is that we will identify when and how to use oxygen. We will try to learn what oxygen delivery devices should be selected and when, and how to monitor oxygen safety levels, and how to educate patients on home oxygen use. So just a review of basic knowledge. I don't need to delve deeply into these slides. Oxygen was discovered by Priestley in 1800s, and it was developed further by Lavoisier, and it was only in 20th century that it was recognized as a therapeutic agent, which is critical for survival and treatment. Its administration is oftenly misused or poorly understood. Hypoxia uh, is the most common indication for oxygen therapy. Hypoxias can be hypoxemic or normoxemic, which is related to our setting. So low partial pressure of oxygen, or even in the presence of normal partial pressure of oxygen, increased tissue demands requiring external oxygen supplementation is an indication for oxygen therapy. So oxygen used in both acute and chronic conditions to supplement low oxygen supply. So commonly in medical wards, acute respiratory failure and or acute respiratory distress syndrome are the commonest indications for oxygen. Postoperative hypoxemia, postoperative atelectasis, and other conditions are uh, the known indications for oxygen supply in surgical departments. Long-term oxygen therapy is another niche that has been gaining very much uh, uh, acceptance in our society, but there are certain barriers like affordability. In our post-COVID era, long-term oxygen therapy has gained acceptance because of the effects of COVID on lungs and permanent fibrosis thereof. Long-term oxygen therapy has been shown to have increased survival benefits, and it has improved pulmonary hypertension and other uh, complications of respiratory failure. But there are certain limits to this thing. Medical Research Council trial in the UK was the first one, and it suggested that long-term oxygen therapy to patients in chronic lung diseases showed significant reduction mortality, and therefore this recommendation was made part of the guidelines in management of chronic lung diseases. Then nocturnal oxygen therapy trial in 1990s showed that continuous oxygen therapy benefits were more significant to the patients compared to those who were given intermittent or no oxygen at all. Then there was another trial which I forgot to mention here, and it compared oxygen therapy, 24-hour continuous oxygen therapy, with at least 15-hour continuous oxygen therapy in patients who were needing long-term oxygen therapy. And they showed that administration of 15 hours, at least 15 hours continuous oxygen therapy was as effective as 24 hours oxygen therapy in patients with chronic lung disease. So these were some advancements published in the research that I've mentioned. We know the equipment for oxygen therapy. We have all been there, going from the compressed gas cylinders to oxygen concentrators to continuous oxygen supply via oxygen plants in admitted patients or ICU patients. We are very much familiar with nasal cannulas, face masks, masks with reservoirs, etc., etc. And of us who have worked in ICUs, they could probably identify other devices such as high flow nasal cannulas or mechanical ventilators. Then there are conserving devices as well, but these are not much used in common practice. So there is a simple question. It's a review of this section. Oxygen, should it be prescribed to all admitted patients? Does the oxygen prescription need any training or knowledge? Should oxygen be prescribed only when needed, or should oxygen administration be via the face mask only? So again, there was no answer. So that's the answer. Oxygen should be prescribed only when needed, and all other options are wrong in this case. So what are risks and precautions? See, every drug, everything that we administer to a human body has its side effects. Even water has side effects. So is oxygen. So oxygen has other risks. For patients who are on long-term oxygen therapy, there is combustion. There is a risk of combustion if they are smokers. There are local physical effects like nasal irritations or mask-induced injuries. There are functional risks as well. Patient may go into hyperventilation, especially if they are COPD patients who are on long-term oxygen therapy, and long-term high oxygen therapy, high inspired oxygen levels can cause structural lung damage. This was uh, mm, this study by Asfar and colleagues showed summarized the benefits and mm, damages of oxygen therapy. By men, for example, oxyhemoglobin saturation was improved, increased vascular partial, microvascular partial pressure was improved. Reduction of nitric oxide led to increased systemic vascular resistance and mean arterial pressure. Inflammation was reduced. Reactive oxygen species were increased, and that resulted in host defense. And like last week, when we heard in Dr. Mubin Sayyed talk about inflammation, reactive oxygen species, when they are increased, they can cause damage to the body. So this side effect, increased oxygen, by maintaining high levels of increased oxygen in blood can lead to increased presence of reactive oxygen species that can lead to decreased nitric oxide production and then oxidative stress and overall damages associated with inflammation. Increased oxygen can also result in rebound, decreased production of nitric oxide, leading to decreased microvascular perfusion and again related damages. The most important thing with giving oxygen is that pulmonary perfusion, ventilation perfusion coefficient is disturbed in the lungs. It opens areas previously closed to oxygen and then it gives a false impression of improvement, although the patient is still hypoxemic. Then this is just a recommendation. If you want to know more about how to give oxygen, what are its important indications or in contraindications or how to give oxygen in different conditions, this review is an excellent starting point for anyone who is not in pulmonology field. I would recommend that you take a screenshot or picture of this thing. So then again, these are basic questions. You either treat hypoxia or you treat hypoxemia. So what's the difference between hypoxia and hypoxemia? It's simple. Hypoxemia refers to poor blood flow and hypoxia refers to low oxygen levels in the blood. So this is the one. Option number one is the answer to that question. Hypoxia refers to low oxygen levels in tissues, while hypoxemia refers to low oxygen levels in the blood. Again, this description of the same thing. Hypoxemia is low level oxygen. Its causes include, among others, lung diseases, high altitudes, heart conditions, etc. Causes of hypoxia can be anything, leading from infection to inflammation to all these diseases, including airway obstruction. How do we treat them? We treat the underlying cause in addition to oxygen supplementation. This is the main thing. You have to make sure that the oxygen saturation in blood is up to par to make sure that there is no structural or tissue damage. And while at the same time, you treat the cause resulting in that hypoxia or hypoxemia. So now we come to our second part. First one was that we covered different basic aspects of oxygen administration. Now, the next one is a bit clinical. So how we give oxygen, what are the needs of oxygen in different clinical settings? So I've summarized them on the slide in front of you. Basically, it's emergency oxygen therapy, then it's non-emergency or home oxygen therapy. It's either ambulatory or short burst oxygen therapy, depending on the patient's conditions. Emergency therapy is usually acute or critical, and this is the one we need the most in patients or in ICU settings. Emergency oxygen therapy can be controlled or it can be uncontrolled. So these are common indications of acute emergency oxygen therapy. For example, low cardiac output with metabolic acidosis, acute myocardial infarction with hypoxemia, severe acute anemia, severe trauma, acute critical care in which there is respiratory distress, documented hypoxemia, and hypotension. Pneumothorax, sickle pain crisis, dyspnea without hypoxemia, or acute MI without hypoxemia, in theory should respond to oxygen administration, but that usually is not the case. However, of the books we have been treating contained pneumothoraces with 100% oxygen supply, and that results in because 100% oxygen supply causes reduction of the nitrogen in the contained space, and therefore it results in expansion of the lung. So these were accepted indications of oxygen need in acute settings. Controlled oxygen is given when you want to avoid the risks associated with indiscriminate use of oxygen. COPD patients, cystic fibrosis, etc., are the most common examples we know from our clinical experience, and we have to make sure that we don't hurt the patients by indiscriminately giving high levels of oxygen. And there are different devices available for them. Venturi masks, Venturi mask valves are the most common, well-known devices for giving controlled oxygen to patients who don't need excessive. And they come in different color grading, starting from blue to green, and their colors help us remember how much oxygen we want to give. So when we read in the books, or when we are told that COPD patients need controlled oxygen at 24% inhalation rate, then we know a Venturi mask would help us. Nasal cannulas, face mask, and all other devices, they do not help us giving patient a controlled dose of oxygen. So for acute management of patients with chronic lung diseases, I think this device needs to be uh, available for management, and it should be a crucial one in addition to other stuff. But I would suggest that they should be given a priority compared to others. So familiarity with how much oxygen is administered with each Venturi mask can help decrease time spent on each patients, and we can give controlled oxygen. So here comes another question regarding this. We have a 70-year-old COPD patient presenting with dyspnea. Pulse oximetry showed uh, oxygen saturation of 87%. What would be the first step? So that is administer supplemental oxygen via nasal cannula or Venturi mask. I think this is the right answer. This is what we need to do. There's no need for uh, administering nebulization or high dose IV steroids. Just supplemental oxygen via nasal cannula or Venturi mask to target an oxygen saturation of 92%. That's the best thing we can do in older patients, older COPD patients with exacerbations. So then there are other devices available for management of acute oxygen needs in critical care, but these are out of our scope. These are usually for clinicians involved in critical care, and we won't touch them, but still they need an honorable mention here in this presentation. High flow nasal cannulas were very common in COVID care in the COVID era, and they help a lot of patients. Non-invasive positive pressure ventilation is a keystone in management of respiratory failure, in especially type 2 respiratory failure. And invasive mechanical ventilation is used when all else fails in maintaining oxygen levels in a critically ill patient. So what are the risks of indiscriminate oxygen use? Can anyone name a few? Okay, we'll move ahead. Stephen Covey, in his book 7 Habits of Highly Successful People, said that you can control your actions, but not the consequences of your actions. Same goes with oxygen. You can give the patient oxygen at any rate, whatever you want, but you cannot control the consequences of that dose. And we'll see how the risk of indiscriminate oxygen use results in a lot of adverse effects on the body. And I've grouped them into main system-wise events. For example, um, pulmonary effects. There was an experiment in which healthy volunteers were given 100% oxygen for varying amount of time. That varying amount of time ranged from 6 hours to 24 hours, and 100% oxygen was given. And all of those healthy volunteers developed tracheitis or alveolitis, uh, even though they had no underlying respiratory illness. So 100% oxygen definitely is dangerous, as suggested by this experiment. Then there is risk of adsorption at electrolysis due to nitrogen washout. Like I said earlier, we use oxygen in contained pneumothoraces to wash out nitrogen to make sure the pneumothorax reabsorption occurs. So the same thing happens in normal lung. Nitrogen washout occurs in low ventilation perfusion areas, and there is adsorption at electrolysis because oxygen only constitutes 21% of atmospheric air. 79% is of nitrogen. You wash out the 79% of volume contained in the alveoli, and the result will be atelectasis. And then lung protective ventilation techniques can help in mitigating these pulmonary effects of vascular effects of hyperoxia or increased oxygen administration. They can cause decreased cardiac output, and they can cause systemic vasoconstriction, especially in cerebral and coronary circulations. Um, they can reduce vasopressor use. They can reduce cardiac output, and they can direct it toward hepatosplanchnic system. However, the reduction in cardiac output is deleterious in some cases, as you will see next in acute coronary syndrome and in case of myocardial infarction. Traditionally, it was given, but then there is a risk of increased arrhythmias, oxygen-induced injury in already necrosed myocardial tissue, as well as uh, as well as cardiac failure. So it is recommended that maximum 94% saturation target should be set in all patients with acute coronary syndrome, even if they have hypoxemia or they don't have any hypoxemia. Cerebral effects in hyperoxia or increased oxygen administration for prolonged times in high doses can cause decreased intracranial pressure in brain injuries, and it may aggravate ischemia, reperfusion injury, and stroke, and it may cause increased mortality after cardiac arrest. So this necessitates the importance of controlling administration of oxygen to patients. And then the last we have perioperative effect. Very a huge number of patients who have symptomatic dyspnea or decreased oxygen saturation after surgery are usually given high flow oxygen. High flow oxygen can cause long-term damages in these patients, and especially in cancer patients, it has a potential for higher long-term mortality. So it is recommended that oxygen should be given in controlled amount. It should be measured and made sure that maximum 94% target of oxygen saturation is not crossed in any case in admitted patients, unless they are critically ill patients, unless they are ARDS patient, unless they are on invasive mechanical ventilation. That is an exception, and that is not our case as of now. So this is another study. This is a study from which I took these um, the previous slide. I summarized this slide from the study, and this was done in 2015, and they briefly described the benefits as well as harms of oxygen therapy. And it's a very good review, and these PDFs are available free for download in Google Scholar once you search them. So then we come to the next thing. Ambulatory oxygen therapy is usually a part of pulmonary rehabilitation program, usually given in chronic lung diseases like chronic lung failure, pulmonary hypertension, maybe cystic fibrosis, interstitial lung disease. Those patients who have ambulatory reduction in oxygen saturation, they usually benefit from ambulatory oxygen therapy. Ambulatory oxygen therapy has its own problems. Carrying the equipment around, you cannot go everywhere. You have to make sure that you are not around people who smoke, or you are near fires, etc. Short burst oxygen therapy is usually given in temporary uses. For example, most commonly we use in hysteric conversion reactions in our emergencies, maybe in cluster headaches, etc., or maybe symptomatic improvement for patients in ER, so that uh, they are satisfied with the management. So this long-term benefit is minimal because it is short burst oxygen therapy, means that it's whatever its effects will be limited to that time only, and they are not going to have any long-term benefits. So long-term oxygen therapy, this is a very familiar piece of equipment to patients as well as doctors. Oxygen concentrators have been launched that concentrate oxygen from the surrounding air, and they provide a fixed rate of oxygen to the patients. They come in different makes and models. They're depending on the patient's requirement, and overall they aim to provide continuous oxygen to patients who need them. Recommendation, as I suggested earlier, that is minimum 15 hours of continuous oxygen therapy to patients. Improved survival in improved survival in different trials such as NOT and MRC. So then we covered acute oxygen therapy, and now there were some clinical practice guidelines developed for how to administer oxygen therapy for adults at home with chronic lung diseases. The focus was on management of COPD, sleep apnea, chronic interstitial lung disease, etc. And they gave certain recommendations that when and where to use oxygen in these cases. So let's see this. Which of the following setting typically requires high oxygen concentration through a reservoir mask? Okay, so let's see what the answer is. And the answer is the same. Severe trauma in ICU. It's the correct answer. And this is it. Chronic COPD patients usually do not require high concentration at 15 liters per minute. Sleep apnea treatment doesn't require high oxygen concentration at 15 liters per minute. Mild pneumonia, oxygen administration is not required. So we move on to clinical practice guidelines again. They defined hypoxemia for the purpose of stratification, for the purpose of giving oxygen to patients. They defined hypoxemia, and they defined severe hypoxemia as partial pressure of oxygen on ABGs less than 55 millimeter mercury, or oxygen saturation as measured on pulse oximetry of less than 88%. Or another one was that the partial pressure of oxygen was between 56 and 59, or oxygen saturation was 89%, but with additional conditions, for example, edema, hematocrit more than 55%, or P pulmonale on ECG. And that's what we use as a criteria for administering long-term oxygen therapy in pulmonary hypertension in our client population. Moderate hypoxemia was defined as oxygen saturation between 89 and 93%, and every patient with oxygen saturation at 94 and above was considered as normal. And severe exertional hypoxemia was described as oxygen saturation of 88% during exercise or activity, which usually return to normal at rest. So these were the defining criteria, and then these guidelines defined the recommendations for these conditions. For example, for severe chronic resting hypoxemia and COPD, they said that there's a strong recommendation of at least 15 hours per day for oxygen administration in these patients, and it was shown to reduce long-term mortality. For moderate hypoxemia, means where oxygen saturation between 88 and 93%, there was a conditional recommendation against LTOT. For example, patients with a stable COPD patient with an oxygen saturation of 90% at rest doesn't always need LTOT, unless until you have proved that the patient has pulmonary hypertension or the hematocrit is more than 55 in adults or more than 50% in adult females, then you may prescribe oxygen. Ambulatory oxygen in severe exertional hypoxemia was conditional recommendation. They said it will improve exercise capacity and outdoor mobility, but overall it did not have any effect on the disease progression itself. LTOT for severe chronic hypoxemia in interstitial lung disease, they said it is a very strong recommendation of at least, again, 15 hours per day. And it was basically an extrapolated evidence from COPD patients. They did not do any specific study on patients with severe hypoxemia who had ILD. So there was no study done. And portable liquid oxygen therapy, they said for patients who need a high oxygen during exertion, they can be given this portable liquid oxygen, but it's usually not always present. So in summary, the most important use for chronic long-term oxygen therapy at home is moderate hypoxemia in COPD as well as chronic severe hypoxemia in ILD, and which means severe hypoxemia means oxygen saturation on pulse oximeter of less than 88% at rest. So we move on to next, how to deliver the oxygen. This is the most important part, because if we have diagnosed the patient correctly, if we have determined the dose correctly, if we have determined the duration correctly, but our oxygen delivery is wrong or it's not effective, then the whole exercise is futile. So how we administer oxygen? A number of devices are there. Let's see what these devices are. Nasal cannulas are the first one usually. They are the first go-to devices we use in patients. They are followed by face mask, then venturi mask, then high flow cannulas or non-rebreathable mask, depending on the patient's severity of the symptoms, as well as when the patient is, where the patient is admitted. For example, if the patient is admitted in ward or the patient is admitted in ICU, and then we have invasive mechanical devices. Usually, the standard procedure is that if the patient has low oxygen demand, the target is achieved at low rates, then nasal cannula is usually sufficient. But nasal cannulas give uncontrolled oxygen. We know that. Nasal cannulas, the delivery oxygen via nasal cannulas is highly unreliable. You cannot be sure that the 2 liters per minute shown in the in that meter above the patient's head is actually delivering 2 liters to the patient. If the patient doesn't respond to nasal cannula, or if the patient needs more than 5 liters per minute, we move on to face masks. If the patient needs more oxygen, then we move on to face masks with reservoirs, and so on. This is the standard procedure. Depending on the need for oxygen delivery, depending on the severity of the patient's illness, and depending on the urgency required, we choose between these devices. So, but the standard thing is again simple. You always start with nasal cannula in a stable patient requiring oxygen. For example, then you move on to face mask. But usually in exacerbation, in patients with exacerbations of asthma or lower respiratory tract or cardiac diseases, face mask is the first option used to maintain oxygen at optimal levels. So again, this is a summary. Target oxygen saturation level 88 to 96 or 88 to 94. And this is how we go. Nasal cannula deliver up to 6 liters per minute. The frequency of inspired oxygen delivered through nasal cannula is variable, but it varies between 24 to 40%. Face masks gives a little bit more inspired oxygen, that is 35 to 60%. And if it is used, if you need to give oxygen more than 6 liters or more than 5 liters up to 10 liters to maintain the target saturation level of at least 88%. Remember, all these devices that we are going to use or that we will probably be choosing depending on the patient. They need a target oxygen saturation. They have to follow this target oxygen saturation that is on left side of the presentation, that is 88 to 96%. No more than 96%. I usually choose 94%. So my aim is to make sure that the patient doesn't have oxygen saturation of 94% and not less than 88%. And that's the safest margin you can play around with using these devices. So first choice typically is nasal cannula. If the patient has a oxygen saturation between 88 and 94, using nasal cannula, there is no need to go for any other devices. If nasal cannula fails to maintain oxygen saturation of at least 88%, the next device is face mask. If this device fails, then usually the next device is face stent or uh, rebreathable mask. So that gives a maximum FiO2 of 50%, and then so on. Venturi masks have a different class. As I said earlier, they are usually used for management of COPD patient in whom we deliberately want to avoid giving increased oxygen, and in patients who we want to give controlled oxygen therapy. And Venturi masks have a separate criteria. They cannot always be used in every patient, but if you still want to give controlled oxygen, Venturi masks are the best devices. You don't need to worry about it. With a Venturi mask of, let's say, 24%, the blue one, if it is in place, it doesn't matter what's the how much oxygen has been turned on at the regulator. Only 24% oxygen will be delivered. Thereby, it decreases the risk of oxygen-induced injury to the patient. And so these things go on depending on the patient's severity and requirement. Again, this simple suggestion is not necessarily applicable in every case. It is not necessarily a rigid structure, but here it is a suggestion that if you start with nasal cannula, it doesn't improve, you go to Venturi mask, doesn't go improve, you go to high frequency nasal cannula, that doesn't improve, you go to CPAP, BiPAP, or maybe ECM, or maybe invasive mechanical ventilation. That depends again on what disease the patient has presented with, and that again depends on what are your aims that you want to achieve in management of that patient. But it's just a suggested sequence, but it is recommended. Again, I'll be emphasizing on this again and again that nasal cannulas or face masks are usually the best things to start with, unless the patient has COPD, where you will be using Venturi masks. So how we monitor oxygen? So we have decided that the patient needs oxygen. We have decided on the dose. We have decided on the mode of delivery. We have decided everything. How do we monitor that our goals are achieved? There are two methods. One is invasive, one is non-invasive. The non-invasive one is commonly used. The invasive one is usually not used until absolutely necessary or unless the patient is in critical care. That is measurement of arterial or venous blood gases. And non-invasive one is pulse oximetry. So pulse oximetry measures peripheral arterial blood oxygen saturation as a surrogate marker for tissue oxygenation. Pulse oximeter use a specific range of wavelengths, red and infrared, 660 and 940 on your screen, and whatever the findings are in between these ranges, it returns that as a percentage of oxygen saturation on that. It's a complicated thing. It's a complicated process affected by a lot of factors. As you can see, reduced hemoglobin, oxyhemoglobin, methemoglobin, or carboxyhemoglobin, they give false readings, even if the patient is, they give false readings on pulse oximetry. We'll go through these limitations in next few slides, but this is how it uses spectrophotometry, and it just calculates the overall concentration using a complex formula, and the percentage is then shown on the pulse oximeter screen. This is a normal, this is a pulse oximeter waveform basically. You can see there's a difference between normal and low perfusion. Motion artifacts is very important because motion artifacts are the most common cause of wrong reading of pulse oximetry. You put on the oximeter on patient's nails and then wait for the reading to come. If the patient keeps on moving their hands, the readings will be wrong, and that may result in a lot of medication errors. So um, advantages: it is rapid, it is non-invasive, and it can give continuous data without any extra fuss. You can carry the pulse oximeter in your pocket. You can use it anywhere. There's no issue whatsoever with it. But there are certain disadvantages, as noted by this research paper published in 2015. Amul Jabran overviewed the benefits as well as limitations of pulse oximetry, and he suggested there were very good insights into the limitations of pulse oximetry. Pulse oximetry cannot detect hyperoxemia. In case you give the increased oxygenation results. You see the oxyhemoglobin dissociation curve. Let me draw it here roughly. The oxyhemoglobin dissociation curve goes like it reaches a plateau starting from zero. Oxyhemoglobin dissociation curve reaches a plateau, and when it reaches 90%, like let's say here, there's no much difference in giving oxygen over to 100%. Pulse oximeters usually show no difference. As soon as the oxygen level is reached at 90%, there's no difference in their readings. While this increased partial pressure of oxygen can be measured with the measurement of ABGs, they are usually indetectable with uh, pulse oximeter. So hyperoxemia, like we suggested earlier, which has its own effects, pulmonary, cardiovascular, cerebral, as well as perioperative side effects, they are undetected with the use of pulse oximetry. You need to have ABGs routinely measured in these patients who you think have these complications of increased oxygen therapy. It cannot measure the arterial oxygen tension, and it cannot measure ventilation. It cannot measure the carbon dioxide production, and therefore, just because the patient has 100% or 98% or 94% oxygen saturation on pulse oximetry does not mean that the patient does not have hypercapnia or the patient does not have hypocapnia. This is very important. These are very important limitations of pulse oximetry. So then in critically ill patient with oxygen saturation of 90% or higher, the mean difference with a co-oximeter was less than 2%. However, this means that any patients who have oxygen saturation of, I would say, we used what we learned during our training and what we had in our mind was that oxygen, all pulse oximeters have a flawed or unreliable accuracy when the oxygen saturation drops below 80% on them. So if you have, for example, you're doing ward round and you do pulse oximetry of a patient to measure oxygen saturation and it shows 54%. So it could be 54%, it could be 4%, it could be 64%. These are highly unreliable. They are only as effective when the oxygen saturation is 90% or above, or I would say 88% and above. Below that, anything that you find on oxygen pulse oximetry that needs to be confirmed with a part ABG in order to be safe and in order to avoid any damage to the patient. This is very important for you people, especially who are in medicine. 89% should be your threshold. Below 89%, any reading on pulse oximeter is unreliable. It's affected by a lot of factors. peripheral vasoconstriction, cold weather, Raynaud's disease, nail polishes, skin pigmentation. There are so many other issues that can cause decreased oxygen saturation and faulty readings on pulse oximetry. Therefore, it should not always be trusted if it shows oxygen saturation values less than 89 and down to 0. You have to confirm them with arterial blood gases. Factors affecting oxygen pulse oximetry, they said के shape of oxyhemoglobin dissociation curve, dyshemoglobins, dyes, intravenous dyes actually, low perfusion states like cardiac failure, dilated cardiomyopathy, shock, etc. Skin pigmentations, anemia is another factor, nail polishes, and they Henkel, Bean and colleagues, they found out that the difference between the black, purple and dark blue nail polishes affected the oxygen saturation measurement via pulse oximetry more than any other nail colors. Purple, black and dark blue nail polishes affected, and they almost up to 14.4% difference with unpainted fingernails for dark blue nail polishes were noted in their study. So, and then knowledge is important. Limited knowledge. There was a study in which 551 critical care nurses were interviewed. 37% of the nurses did not know that oximeters were likely to be inaccurate when the patients were moving their hands. 15% did not know the poor signal quality could affect the readings, and 30% did not know that 30% considered that it was a best alternative to ABGs in management of patients in ICU. So limited knowledge on part of healthcare providers is more important, but they should also know what other patient factors affect the readings on pulse oximetry. So while you would say, what's the use of pulse oximetry when there are so many limitations to this thing? But pulse oximetry is a very good tool to find out if hypoxemia has started. And in a study of more than 20,000 perioperative patients, pulse oximetry was able to alert the physicians to early hypoxemic phase, and they were able to give patients oxygen. Fractional inspired oxygen saturation in patients required. The patients who are on invasive mechanical ventilators, I'll go with the example of ARDS patient where uh, partial pressure of oxygen versus fraction of inspired oxygen ratio matters in terms of deciding if the patient is mild, moderate, or severe respiratory distress. A study found out that oxygen saturation to fraction of inspired oxygen inhalation ratio was as effective as partial pressure of oxygen to fraction of inspired oxygen saturation, and it reduced a lot of needling of the patients and a lot of the need for taking multiple arterial or venous blood samples just to calculate the ratio. So the next invasive measure for monitoring oxygen therapy is ABGs. Like I said, it's an invasive. It identifies oxygen levels as well as acid-base disturbances, helps in determining partial pressures of oxygen and carbon dioxide, and other. It has other benefits, but there are problems with this thing. Cannot be done with cannot be done by everyone. Training is required. Distorted anatomy may result in damage to the patients and cannot be done in almost any patients. And active Raynaud's syndrome is particularly contraindication to this procedure. So summary of this whole talk that we have been for most emergency cases, an oxygen saturation of 94 to 98, I would say 94 to 96% of most emergency cases, oxygen saturation of up to 92% for COPD or other chronic diseases, and less than 98 for all other diseases. Never never aim for 100% oxygen saturation in any patient admitted to the hospital, unless required by the patient's condition or if the patient is in ICU. So key takeaways, emergency oxygen is more important, helps, saves lives, but it is important that oxygen should be given in controlled format. Uncontrolled oxygen has its side effects. Home and ambulatory oxygen uses have been gaining with the increase in chronic lung diseases, and safety should always be the first thing when you prescribe oxygen to any patient. So it is regular monitoring is a wide needed. Pulse oximetry is a very good tool for monitoring the patient, but it has its own limitations. Any reading of pulse oximeter should be interpreted in that clinical setting. Patients should be educated regarding the use of pulse oximeter as well as oxygen use, and they should be educated how to titrate their oxygen therapy, especially when they are on chronic long-term therapy like COPD or therapy. So this was all. I hope I didn't take a lot of your time. I'm
Thank
ready
you
for
so much, Dr. Munir. And before going to question answer session, I will request Dr. Rafiq Saab if you want to say something. इसको ज़रा unshare कर दें, screen को unshare कर दें.
इसको ठहरे में इसको मैंने दूसरी स्क्रीन पे किया हुआ है.
हाँ जी, डॉक्टर रफीक साहब, आप फरमाएं.
जी डॉक्टर रफीक. ओके, चलें, इस देर में डॉक्टर रफीक साहब आते हैं. इफ एनीबॉडी वांट टू आस्क द क्वेश्चन. मेरा एक सवाल है डॉक्टर रफीक साहब. आर यू देयर? हेलो डॉक्टर रफीक, आर यू देयर? Can you unmute and give answer of the few questions? Dr. Rafiq, Dr. Munir साहब, are you there? Okay. डॉक्टर मुनीर साहब, मुझे ये सबसे पहले ये बताइएगा, ये बड़ी चीज़ें उस ज़माने में आई व्हेन देयर वाज ए कोविड एंड इंट्रोडक्शन. अल्हम्दुलिल्लाह, थैंक्स अल्लाह के उसने हमें इतनी प्लेजेंट ऑक्सीजन दी है, बगैर पैसे के दी है. फ़ाबे ये आलाए रब्बे को मातो कज़बान. पहला सवाल तो मुझे ये बताएं, व्हाट इज़ ऑक्सीजन टॉक्सिसिटी?
Oxygen toxicity is basically characterized by the damaging effects of oxygen on blood tissues. Normally हम simple अल्फाज में इसको कहते हैं कि free radicals generate होते हैं higher oxygen level से. These free radicals cause damage to the body tissues, and whatever effects that result from these reactive oxygen species is called as oxygen toxicity.
मुझे ये बताइए, होती कैसे है, क्यों होती है? ऑक्सीजन पेशेंट ले रहा है, क्यों होती है?
सर मैंने एक स्लाइड शेयर की थी, उसमें
आप अपने सिंपल अंदाज में बताएं ताकि हम सारे लोग समझ जाएं और आगे आने वाले स्टूडेंट्स को भी
अच्छा,
बताएं.
मैं आ गया हूँ. जब भी मुझसे सवाल
गिव मी फ्यू मिनट्स, आई विल कम टू यू. डॉक्टर मुनीर साहब, मुझे ये बड़ा सिंपल अल्फाज में बताएं, ये क्यों होती है?
क्यों होती है?
ऑक्सीजन ले रहा है और ऑक्सीजन टॉक्सिसिटी क्यों हो रही है?
the क्या कहते हैं, सेचुरेशन हो गई होती है body system.
If you are going to uncontrolled, if you are going to give the oxygen uncontrolled without any keeping in knowledge, कुछ जहन में आपके नहीं है और ऑक्सीजन दिए जा रहे हैं और पेशेंट को ज़रूरत नहीं हो रही है, ओवर सेचुरेशन हो रही है, तो इसका मतलब ऑक्सीजन सेचुरेशन होती है. यही कोविड के अंदर बहुत ज़्यादा हुआ. मैं आपकी तरफ आता हूँ. रफ़ीक साहब, अपना ज़रा चेहरा भी दिखाएं और अपनी वो भी करें अपना सवाल. आप अपने ओवर टू यू डॉक्टर रफ़ीक साहब, ओपन योर वीडियो एंड ओके, थैंक यू सो मच. एंड आज तक क्वेश्चन, अगर आप कमेंट देना चाहें तो मोस्ट वेलकम.
अस्सलाम वालेकुम.
जी, वालेकुम
माशाअल्लाह,
अस्सलाम.
अस्सलाम वालेकुम to everyone. It was a very nice presentation by Dr.
अल्हम्दुलिल्लाह,
Munir Abbasi Saab,
अल्हम्दुलिल्लाह.
and it was a very important topic. And you might be knowing that Pakistan Pediatric Association has developed a national oxygen guidelines, and we in all the pediatricians from the higher level working in ICUs and nurses, and we have trained throughout Pakistan how to, because oxygen is a drug. Now, one concept always it is a drug. It can, if it is not
Yes,
given
it is a
in high,
drug.
it is a drug. It is given in higher doses, it will be toxic. It is given in
And
a
we are
low.
interventing it. We are interventing it.
Yes. So there should be proper national guidelines of the oxygen therapy at the pulmonologist level, at the internal medicine levels, or all the healthcare professional levels. This is my suggestion. And my comment was, it was
Good
an
suggestion,
excellent
inshallah.
presentation on a very important topic. Thank you, TMA. Thank you, Dr. Salma Kundi. Thank you, Professor Mulazim Hussain Sahab.
थैंक यू सर, थैंक यू डॉक्टर रफीक। अच्छा, ऐसा है कि आई एम आपकी तरफ दोबारा आ रहा हूँ कि ऑक्सीजन थेरापी तो हो रही है आजकल, नज़ला ज़ुकाम खांसी ज़्यादा है, और ये मौसम है, और ये हमारा कौमी निशान भी आलमोस्ट बन गया है, एवरी पर्सन इज सफरिंग विद। मुझे बताएं इसके बारे में, ये बताएं कि ये नज़ला ज़ुकाम इस मौसम में क्यों हो जाता है?
सर सर्दियों में
Variability of temperature variability,
जी जी
जो
जी, मुनीर
temperature.
साहब, मुनीर साहब, जी 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 जी, मैं
सर एक तो ये कि सर्दियों में ये जितनी भी ऐसी सिम्टम्स होती हैं, दीज आर वायरल इलनेसेस।
वायरल,
बस इसमें और इससे कोई और बात नहीं है। एक तो ये कि वायरल इलनेसेस हैं, मौसम की वजह
ये
है।
कोई पाकिस्तानी वायरस है या कोई और वायरस है?
ये पूरी दुनिया में ऐसा होता है।
अच्छा, इसका नाम क्या है सर?
फ्लू, इन्फ्लुएंजा वायरस।
इन्फ्लुएंजा वायरस, इन्फ्लुएंजा वायरस। अच्छा, ये बताएं कि जब कोविड आया तो 2 साल तक ऑलमोस्ट फ्लू फ्लू बंद हो गया था, तो लोगों ने उसकी वजह ये है कि मास्क इस्तेमाल किया और काफी
मुलाजिम साहब, इसमें कोई बात कर सकता हूँ? जो आपने नजले
सर मैं
जुकाम
आपको,
की
सर
बात
आप
की
तो
है।
मुझे बताएं, आप, आता हूँ सजाद के, सर आता हूँ आपकी तरफ, आता हूँ सर, मैं आपकी ईएनटी स्पेशलिस्ट हैं, मैं आई स्पेशलिस्ट है, मैं आपकी तरफ ईएनटी स्पेशलिस्ट आता हूँ सर। अच्छा, ये बताएं कि ऐसा ही है कि ये मास्क वगैरह इन्होंने छोड़ दिया है, तो अगर एक को हुआ है तो दूसरे को हो गया है, ऐसा ही है?
सर ये एक इंटरेस्टिंग बात थी कि जब कोविड के इनिशियली 2 साल में हमारे पास बहुत कम एस्मा और सीओपीडी एक्सरबेशन विंटर में आए, एंड दैट वाज रियली सरप्राइजिंग। एंड
सरप्राइजिंग।
यस यस, दैट वाज रियली सरप्राइजिंग। और एक फार्मा कंपनी के जो थे सेल्स मैनेजर, उनसे बात हुई तो उन्होंने कहा ओवरऑल उनकी नेशनल सेल्स 18% ड्रॉप हुई थी, ये इनहेलर्स की और इन ब्रोंकोडायलेटर्स की जो एमडीआई या डीपीआई फॉर्म में है। सो दैट वाज रियली स्ट्रेंज। और इंटरेस्टिंगली हम पिछले महीने ये डिस्कस कर रहे थे कि अगर कोविड में ये खत्म हो सकती थी तो अभी भी खत्म होनी चाहिए, बट
उसकी वजह यही थी,
पीपल।
उसकी वजह यही थी कि हमने वो अडॉप्ट किया वो चीज़ें। अच्छा, मुझे आप बताएं कि ये खांसी नज़ला ज़ुकाम जो एक आम सी चीज़ है, मैं सजाद कैसर की तरफ जाने से पहले, ये नज़ला खांसी ज़ुकाम है, इसके लिए क्या क्या करें जब हो जाता है तो क्या करें?
सर ऐसे सब पेशेंट्स को बुनियादी तौर पे एक ईएनटी स्पेशलिस्ट के ओपिनियन की ज़रूरत है। और
बैठे हैं,
डॉक्टर,
अब ईएनटी की तरफ जाता हूँ, आप पल्मोनोलॉजिस्ट बताएं सर।
सर मैं तो रिकमेंड करता हूँ कि एंटी हिस्टामिन, डीकंजेस्टेंट और दैट्स इट, ये काफ़ी हैं। अनलेस द पेशेंट हैज फीवर, अनलेस द पेशेंट हैज रेज्ड टीएलसी, देयर इज नो नीड फॉर एंटी।
एंटीहिस्टामिन, डीकंजेस्टेंट और एक्सपेक्ट, ये इसको काफ़ी है। अच्छा, ये मुझे बताएं कि क्या इसके अंदर बड़ा अक्यूट सा वो हो जाता है, हालांकि एस्मा नहीं होता, लोग फील करते हैं हमें एस्मा हो गया, चेस्ट कंजेस्ट हो गई है, ये दिस इज ऑल ड्यू टू वायरस?
दिस इज ऑल वायरस पोस्ट नेजल ड्रिप
एक्चुअली,
की।
एक्चुअली ऐसा है कि एज ए पैथोलॉजिस्ट मैं देखो, वो इन्फ्लेमेटरी मार्कर जो होते हैं ना, वो इन्फ्लेमेटरी मार्कर्स होते हैं हमारे जो एल्वियोलाई है, और उसको वो कंजस्ट कोलैप्स करते हैं। जब वो कोलैप्स करते हैं तो हमारी कंजेशन होती है, दैट इज़ वाई आप कह रहे हैं कि हमें डिकंजेशन होती है। जी डॉक्टर सजाद कैसर साहब, आप, शर्त ये है कि आप चेहरा दिखाएंगे तो सवाल की इजाज़त है। जी जी, सजाद कैसर साहब, डॉक्टर सजाद कैसर
जी हाँ बिल्कुल।
सर, अपना
मैं
चेहरा ओपन करें, ओपन करें, चेहरा ओपन करें।
सर चेहरा ओपन नहीं कर पाऊंगा, मैं एक्चुअली कुछ काम कर रहा हूँ, तो
जी जी, आप बताएं उस
मैं
सवाल के
मैं
जवाब के कि ये आजकल
मैं
जो नज़ला खांसी जुकाम हो रहा है, इसके बारे में सर आप सवाल बताएं।
मैं ये कहता हूँ कि देखें, प्रॉब्लम हमारे यहाँ कुछ ऐसा है कि हमारा लाइफ स्टाइल, जो आपका बेसिक सवाल था कि ये जो इस मौसम में ये नज़ला जुकाम क्यों हो जाता है, एक्चुअली हमारा जो इम्यून सिस्टम है वो बहुत खराब हो चुका है बिकॉज ऑफ लाइफ स्टाइल। और लाइफ स्टाइल ये हो गई है कि हमारा जो डाइट का सिस्टम है, डाइटरी जो हम चीजें खाते हैं, वो सारा का सारा बहुत प्रॉब्लम वाली बात है। और हमारे सोने का सिस्टम जो है वो भी बहुत
नींद
खराब
का,
हो चुका है।
आराम का, आराम
नींद,
का
जी, हम रात भर जागते हैं।
जागते
खासकर जो पेशेंट हम देखते हैं, यंग लड़के लड़कियां जो स्टूडेंट्स हैं, उनका कहना यही होता है उनके पेरेंट्स का कि जी ये रात भर पढ़ती हैं,
सारी रात जागते हैं।
सारी रात जागते हैं और पढ़ते हैं। तो और ये हर घर का मोस्टली मैं समझता हूँ पाकिस्तान
ये
में।
हर घर का डायलेमा है।
पहले तो ये मैं समझता था कि इस्लामाबाद में लोग देखता था तो मगरिब के या इशा तक तो बिल्कुल ऐसा अंधेरा होता था कि कोई शहर में रहता ही नहीं है। लेकिन अब इस्लामाबाद भी जागता रहता है काफी देर तक। तो ये जो लाइफ स्टाइल है ना, ये इम्यून सिस्टम खत्म करता है। जब
इम्यून
इम्यून
सिस्टम
आपका खत्म होता है या कमजोर होता है, वीक होता है, तो आप समझ लें कि आपको बहुत सारी वायरल इश्यूज आपको बहुत जल्दी होंगे। और ये बिल्कुल करेक्ट बात है कि जो ये चीजें हैं मोस्टली वायरस है, बैक्टीरिया भी है लेकिन मोस्टली वायरस है। तो अब होता ये है कि हम जब मौसम चेंज होता है, टेम्परेचर हमारा डाउन होना शुरू होता है, क्योंकि हम एसी और फैन और ठंडे मशरूबात और ये सारी चीजों पे चल रहे होते हैं, तो हम वो कंटिन्यू करते हैं। साथ में वो लोग जो कि सेंसिटिव होते हैं इन चीजों के, ठंडी चीजों के, खट्टी चीजों के, उनको ज्यादा जल्दी होता है, सिस्टम शुरू हो जाता है। फिर जो तीसरी चीज है वो है पॉल्यूशन। हमारे यहाँ पॉल्यूशन बहुत है
बढ़
और ये
गई है, बढ़ गई
पॉल्यूशन
है।
बहुत दिन ब दिन बढ़ती चली जा रही है। उसकी वजह
हमें
से
हैदराबाद जाना चाहिए, जदून साहब के पास, जहाँ पोल्यूशन नहीं है।
बिल्कुल हमें जो ये मौसम शुरू हो
मैं बस एक
तो
बात, सॉरी सजाद, आपको मैं काट रहा हूँ।
जी जी, तो
मुलाजिम
डॉक्टर
साहब जो
जी,
सारे सुन रहे हैं, तो ये असल अपना कैसर जो है इतनी जल्दी मुंह नहीं दिखाते होते, इनको मुंह दिखाई देनी पड़ती है तब ये मुंह
चलें।
दिखाते
अच्छा जी जी, आप सर कुछ कहें अपने
अजहर भाई
डिवीजन के बारे
अस्सलाम
में, जदून
वालेकुम।
साहब कुछ
मुझे
कहें
देख
फिर
के
उसके
आपको
बाद
बड़ी
से।
खुशी हुई है और फिर मैं कोशिश करता हूँ कि मैं भी आपको दिखा दूं अपना
हाँ
चेहरा
हाँ
चेहरा।
हाँ जी जी, मैं
मेरे
देखिए ना,
भाई ने
मुंह
दिखाया।
मुंह मुंह दिखाई का कुछ देना पड़ता है ना
नहीं
तब।
नहीं, बिल्कुल बिल्कुल बिल्कुल, मुझे
ठीक है
बड़ी
सर
खुशी हुई
सजाद,
है
आप
आपको
कुछ
देख
कह
के।
रहे थे।
चले चले
एनीबडी?
चले, अब
तो
आप अपना वेबिनार जारी
मैं
रखें जी।
मैं ये कह रहा हूँ कि ये जो सिस्टम है, भाभी को भी सलाम, बहुत जबरदस्त। मैं ये कह रहा हूँ कि ये जो सिस्टम है हमारा, लाइफ स्टाइल और डाइट का सिस्टम है, इसको हमें कंट्रोल करना पड़ेगा और हमें लोगों को बताना पड़ेगा कि आपका जो लाइफ स्टाइल है इसको चेंज करें। खुदारा इस्लाम में, जो कुरान की आयत आपने पढ़ी, उसमें कुरान में भी ये लिखा हुआ है कि और जब मगरिब की अजान हुआ करे तो अपने काम बंद किया करो। ये उर्दू तर्जुमा है। और एक जगह पे लिखा हुआ है कि रात तुम्हें आराम करने के लिए दिया गया है। हमारे यहाँ उल्टा होता है और
उल्टा
ये
होता है।
बिल्कुल लॉजिक है। साइंस, जो मेडिकल
बहुत
साइंस है
खूबसूरत
वो
बात
ये
की आपने।
कहती है, जो मेडिकल साइंस है वो ये कहती है कि रात को यानी कि अंधेरे में सोना 7 to 8 hours इज मस्ट। रात को अंधेरे में, जो लोग ये कहते हैं, बहुत सारी खवातीन आती हैं कहती हैं डॉक्टर साहब हम तो बच्चे को है वो स्कूल भेज देते हैं, वैन आती है, उसके बाद आके मैं सो जाती हूँ और जब वैन आने का टाइम होता है 1-2 बजे फिर उठती हूँ, मैं तो बहुत सोती हूँ। तो ये सोना नहीं होता है। मेडिकल साइंस कहती है ये सोना नहीं है। अगर आप फजर की जो वो रोशनी शुरू होती है फजर के बाद, उसके बाद अगर आप सोते हैं तो दैट इज नॉट गुड। तो रात को सोना इज वेरी गुड। आप देखें कि अगर मैं बार बार लोगों से कहता हूं, मैं आपके जितने भी पार्टिसिपेंट्स हैं उनसे यही कहूंगा कि आप भी इससे बताएं लोगों को कि भाई आप लोग गलत काम कर रहे हो। आप नोट करें कि जो लोग रात को जागते हैं, प्रोफेशनल वाइज जो आर्टिस्ट हैं, जो रात को
उनकी
प्रोग्राम
इम्यूनिटी कम
करते हैं,
होती है, वो जल्दी मर
उनकी
जाते हैं।
इम्यूनिटी कम होती है, प्लस उनकी लाइफ स्पैन भी कम होता है।
मर
वो
जाते हैं
ज्यादा
जल्दी।
अरसा नहीं
बिल्कुल सही
जीते
कहा
हैं।
आपने, बिल्कुल
देखिए
सही
मैं
कहा आपने।
मिसाल देता हूं, मेरा दोनों बड़े अच्छे दोस्त थे मेरे, उमर शरीफ और उमईन अख्तर। ये बहुत जल्दी चले गए दुनिया से क्योंकि रात भर प्रोग्राम करते थे, मुझे पता है। और ये 7-8 बजे रात को सुबह नाश्ता करके फिर सोते थे और
कैसर
मगरिब
में,
की।
कैसर सजाद में आपको इसका जवाब दूसरा दे दूं। मेरे वाले साहब 95 ईयर के थे और बगैर किसी डिजीज के इस दुनिया से गए, नॉर्मल नेचुरल डेथ हुई, और उनका तरीकाकार ये होता था कि नमाज इशा पढ़ के सो जाते थे और सुबह 5 बजे उठ जाते थे। ये लाइफ वाला स्टाइल अपनाएं।
जी,
थैंक यू सो मच
दिस इज,
डॉक्टर कैसर
यही मैं
सजाद।
कह रहा हूँ।
जी जी
यही मैं कह रहा हूँ कि इसको हर को फॉलो करना पड़ेगा। जो भी काम करना है, फजर की नमाज के बाद उठ के पढ़ना है, कोई काम करना है, तो आपको इस टाइम पे काम करना होगा। तो मैं समझता हूँ कि
थैंक यू सो मच सर।
वैसे कैसर भाई,
जी
मुलाजिम
डॉक्टर
साहब
जी
एक
जी
सलमा,
बात
बोलिए,
अर्ज
ओवर टू
करूं?
यू। जी जी प्रोफेसर सलमा।
जी, इतना अच्छा
जी
लेक्चर दिया है हमारे बहुत ही अच्छे असिस्टेंट प्रोफेसर डॉक्टर मुनीर अब्बासी साहब ने। और मैं थोड़ा सा ये अर्ज करना चाहती हूँ कि पर्सनली मैं अगर ठंडी हवा में बाहर जाऊं या वॉक करूं, या इफ द कोल्ड एयर हिट्स मी ऑन द फेस, मुझे जुकाम शुरू हो जाता है। एंड प्रोबेबली
आप
इसमें विटामिन डी की कमी का भी कोई आंसर मौजूद होगा। और कोरोना के दिनों में ये जो मास्क ने हमें बचाए थे, एक तो ऑब्वियसली वायरसेस और बैक्टीरिया से बचाया, लेकिन उसके अलावा मुझे लगता है वो जो ठंडी हवाएं नहीं लगती थी हमें, हम उससे भी बचे रहे। तो
देखिए, आपका जो आप जो बता
जी जी कुछ
सेंसिटिव है
कह
ठंडी
रहे
हवा से, ठंडी ठंडी हवा से आप
एनीवे,
सेंसिटिव है, तो
हाँ
उसके लिए
एग्जैक्टली।
उसके लिए दी बेस्ट तरीका यही है कि कोविड ने में के दौरान इजाद हुआ मास्क। वो जब आप ऐसी जगह पे जाया करें तो प्लीज मास्क जरूर लगा लिया करें। मास्क ना अगर हो तो आप दुपट्टे के जरिए आप नोज को कवर कर लिया करें। एंड दिस इज एब्सोल्युटली, मैं अप्रिशिएट करूंगा मुनीर अब्बासी साहब को कि इतनी अच्छी तालीम बालगान हमारी हो गई है कि बहुत सी चीजें हमें ऑक्सीजन के बारे में पता लगा। और ये बात दुरुस्त है कि मैं भी बड़ा सोचता हूँ, हम ईएनटी वाले तो इतना ज्यादा ऑक्सीजन से नहीं खेलते, लेकिन ये कि ये बता दीजिए मुझे कि इन्होंने भी मुलाजिम साहब ने भी कुछ इसी तरह का क्वेश्चंस किया था। मेरे जहन में भी दो चार सवालात हैं। नंबर एक सवाल तो ये मैं कर लेता हूँ कि घर पे ऑक्सीजन दिया जाता है, तो उसको कैलकुलेट कैसे करें कि ये एक्सेस ना हो जाए या कम ना हो जाए? ये कैसे
टॉक्सिसिटी ना हो।
हाँ, टॉक्सिसिटी ना हो, एक्सेस ना हो और कमी ना हो, तो हम इसको कैसे कैलकुलेट कर सकते हैं?
जी डॉक्टर
अच्छा,
साहब।
ये भी मुनीर साहब, ये भी बड़ा, मैं आपको बताऊं, ये बड़ा कॉमन है कि अनफॉर्चुनेटली लोग ये समझते हैं कि जी ऑक्सीजन देना है, बस दे दो। ये क्या वो अब्बा के नाक में लगा दिया है और वो ऑक्सीजन चल रही है। भाई कितना देना है और उसको किस कब तक देना है, क्या ड्यूरेशन है, ये बड़ा इंपॉर्टेंट
जी
है,
मुनीर
तो मैं
अब्बासी
जरा
साहब,
मालूम करना।
बहुत
जी
आप समराइज करेंगे और इसके बाद हम कंक्लूड करेंगे। जी जी
इस तरह है कि जो मैंने इस दौरान बताया कि क्रॉनिक लंग डिजीज गाइडलाइंस इशू हुई थी, ओवरऑल बीटीएस भी ये सजेस्ट करती है, बाकी थोरेसिक सोसाइटीज भी, कि आपने बहुत ज़्यादा तो नहीं करना। लोगों के जहन में शायद ये होता है कि जैसे मोबाइल की बैटरी 100% चार्ज हो गई है तो हमने ऑक्सीजन भी 100%
ऑक्सीजन
चार्ज
भी
लगा।
चार्ज होती रहेगी।
हाँ, वैसे नहीं होता। सो एक एक खास हद तक फायदा होता है, उससे ज्यादा नुकसान हो जाता है। मतलब
नुकसान हो
जैसे
जाता है, टॉक्सिसिटी हो जाती है।
लैपटॉप की बैटरी 100% नहीं करनी चाहिए, 85% तो रखें, ओवर चार्जिंग नुकसानदेह होती है। सो द रिकमेंडेड टारगेट इज सर, डिपेंडिंग ऑन द डिजीज, डॉक्टर सजाद, डिपेंडिंग ऑन द डिजीज वो क्या है। इफ इट इज सीओपीडी, जिसके लिए लॉन्ग टर्म ऑक्सीजन है, या कॉर्पल बन चुका है सीओपीडी विद पर्मनंट हाइपरटेंशन, तो 92% से ऊपर नहीं जाएगा किसी भी सूरत में। अब वो 92 1 लीटर पर मिनट पे अचीव हो रहा है, 2 पे हो रहा है, 3 पे हो रहा है, ये पेशेंट की अपनी डिजीज पे डिपेंड करता है।
क्योंकि उसके लंग की कैपेसिटी कम हो गई है अब।
हाँ, वो उसकी डिजीज से डिपेंड करता है कि वो ठीक इतनी ऑक्सीजन स्टार्ट कब हुई है। अर्ली स्टार्ट हुई है तो यूजुअली 1 लीटर पे, हाफ लीटर पे मेंटेन हो जाएगा। अगर देर से स्टार्ट हुई है तो देन मोस्ट प्रोबेबली इट्स गोइंग टू बी 3 लीटर, 4 लीटर में भी, 5 लीटर में भी शायद वो ऑक्सीजन कंसंट्रेट चेंज करना पड़े, 10 लीटर पे जाना पड़े। बट देन अगेन इट डिपेंड्स। लेकिन हमने लीटर्स पर मिनट पे नहीं जाना, हमने ऑक्सीजन सेचुरेशन टारगेट देखना है। फिर उसमें कुछ चीज़ें हैं, जैसे मैं बताया वो लिमिटेशंस हैं। पेशेंट एनीमिक ना हो, पेशेंट पिगमेंटेड नहीं हो, ठीक है, ऑक्सीजन सेचुरेशन चेक करते वक्त हाथ मोशनलेस हो, ये चीज़ें, ये इंपॉर्टेंट चीज़ें हैं। या अगर सेचुरेशन चेक करनी है तो आधे घंटे तक ऑक्सीजन बंद करके रखनी है, ताकि हमें क्लियर कट पता चल जाए कि बेस लाइन ऑक्सीजन के अलावा क्या सिचुएशन है, उसके हिसाब से करें। तो एनीमिया इटसेल्फ कॉजेज डिक्रीज ऑक्सीजन सेचुरेशन।
ऑलरेडी
बहुत,
उसमें कम हो जाती है।
हाँ, हम बहुत से केसेस में देखता हूँ कि रॉन्गली रिकमेंड उनको किया गया होता है कि पल्मोनोलॉजिस्ट ओपिनियन है या आईसीयू एडमिशन है, बिकॉज डायलेटेड कार्डियोमायोपैथी है, 25% या 30% इंजेक्शन फ्रैक्शन है, पेरिफेरल वेसोकंस्ट्रिक्शन उसकी ऑलरेडी है, हाथ उसके ठंडे हैं, आप उस पर ऑक्सीजन सेचुरेशन चेक करेंगे तो वो तो 50% भी नहीं आएगी शायद।
बिल्कुल नहीं आएगी।
हाँ, तो वो फिर रॉन्गली रिकमेंडेशन हो जाती है कि दाखिल करें जी, ऑक्सीजन दें। तो अंडरलाइन कॉज को ट्रीट करें, अंडरलाइन कॉज। तो जो सर का क्वेश्चन था रेलेवेंट, उसका जवाब ये है कि अकॉर्डिंग टू द डिजीज, अगर सीओपीडी है तो मैक्सिमम 94 है, अगर
हाँ,
इंटरस्टिशियल डिजीज है तो 90, सॉरी सीओपीडी
एक्चुअली हमने उसकी सेचुरेशन को देखते रहना है, वो मॉनिटर करने का बेहतरीन सिंपल घर में यही तरीका है, उसकी सेचुरेशन को चेक करते रहे।
पल्स ऑक्सीमीटर।
दे एक सिंपल सा तरीका है कि उसकी वो करता है। थैंक यू सो मच डॉक्टर मुनीरा, क्यों टाइम बहुत ज़्यादा हो गया है। मैं डॉक्टर प्रोफेसर सलमा कुंदी, ओवर टू यू टू कंक्लूड टुडे सेशन। प्रोफेसर सलमा कुंदी, ओवर टू यू। हैं प्रोफेसर सलमा हैं? जी डॉक्टर सज्जाद, फिर आप ही कंक्लूड कर दें। डॉक्टर सज्जाद आप ही कंक्लूड कर दें।
ठीक है, राइट, ओके। मेरे ख्याल में शायद कहीं पे बिजी हो गई हैं। ओके ओके,
इस्लामाबाद
थैंक
से
यू
जा
वेरी
रही थी,
मच।
इस्लामाबाद से जी।
ओके, थैंक यू वेरी मच मुलाजिम साहब। मैं समझता हूँ कि टुडे द टॉपिक एंड द स्पीकर वाज एक्सीलेंट। मैं
एक्सेलेंट।
अप्रिशिएट करता हूँ मुनीर अब्बासी साहब को फॉर द एक्सीलेंट प्रेजेंटेशन about an important topic for all the doctors, not for the pulmonologists only, but all the doctors. They should know the basic knowledge of the oxygen supply or oxygen कब कैसे क्या देना है. And I also thankful to all the participants के इतवार के दिन सारे लोग आए हैं, all the participants, और again thankful to all the participants who participated, like Dr. Rafiq Saab, Dr. Rashid Saab, Dr. Salma Kundi,
ऐसा
and
है डॉक्टर
my
अयूब
friend
है,
Azhar Ayub Saab ने, तो everybody, सबके लिए मैं शुक्रगुजार
आशिफ
हूँ
साहब,
on behalf of the Pakistan Medical Association and their allied जितने भी हैं, पैथोलॉजी एसोसिएशन और जो एबटाबाद मेडिकल कॉलेज और सारे लोग जितने भी लोग हैं इसमें, उन
डॉक्टर
सबको
खुशबख्त बैठे हैं। जी जी बिल्कुल
जी
बिल्कुल।
खुशबख्त, उनका भी बहुत बहुत शुक्रिया। तो अगेन जो एंड में मैं शुक्रिया अदा करता हूँ मुलाजिम साहब का, और माय माय यंग एल्डर सिस्टर सलमा कुंडी का, कि इनके विजन के साथ ये काम चल रहा है, और मुलाजिम साहब जिस तरह से कंडक्ट करते हैं, एक्सीलेंट आपकी जो है वो होती है, इसको कंडक्ट करते हैं, मॉडरेट करते हैं। आई एम अगेन थैंकफुल टू यू मुलाजिम साहब, एज यूजुअल आप खुश रहें, और तमाम लोगों
थैंक यू,
को के लिए दुआएं हैं। थैंक यू वेरी मच एवरीबॉडी।
थैंक यू
सी
सो
यू
मच सर।
सी यू नेक्स्ट टॉपिक नेक्स्ट वीक।
थैंक यू सर, थैंक यू। ये
थैंक यू वेरी मच।
एक देखता हूँ कोई क्वेश्चन और है। पाकिस्तान मेडिकल एसोसिएशन टू इवेंट्स, ओके, डॉक्टर रफीक साहब का भी शुक्रिया। थैंक यू वेरी मच। इंशाल्लाह सी यू नेक्स्ट संडे इंशाल्लाह। और ऐसा होता है कि हम थोड़ा सा सजाद कैसर के एक ओवरलैप होता है, एक वेबिनार बड़ा तालीमी सा है। हम चाहेंगे कि जब वो वेबिनार, वो भी 11 बजे का है, तो या तो हम उस दिन रखें ना, या फिर हम टाइम पीएमए का जो वेबिनार है उसको हम ऊपर नीचे करेंगे इंशाल्लाह। थैंक यू सो मच। अल्लाह
थैंक यू।
हाफिज। अल्लाह हाफिज, आप सब हिफ्ज़ अमान में रहें।
अल्लाह हाफिज, अल्लाह हाफिज।
थैंक यू।
अयूब साहब।